So, Karen, this patient does well for 10, 11 months, starts to progress, but just in one site, perhaps in the rib, with increasing pain. Other sites of disease remain stable. They've already shrunken, but they're now stable. How would you handle that patient? Would you switch to one of the second generation ALK inhibitors, or would you go about it differently?
So at this moment in time, I think that the most important thing to do is continue to keep pressure on the driver mutation. So I would continue crizotinib and do localized therapy, in this case probably radiation, to the rib lesion, and continue crizotinib therapy as long as possible. And there are many patients who can go on for a long period of time with oligometastatic disease, receive local treatment, and remain on the initial treatment that blocks the driver mutation. So I think that's the important thing.
Same scenario if the patient developed an isolated brain met or a few brain mets?
Exactly. And one thing we know about crizotinib is that it does not cross the blood-brain barrier well. Some of the new generation agents do, but treating the brain with radiation or local therapy would be the goal.
So when do you think you'd pull the trigger on a second-line ALK inhibitor?
So at this moment, they're not available. So
that's true, right?
So basically, it'll be on clinical trial. Generally, when they have systemic progression, is when I would
multifocal, more diffuse,
or symptomatic progression in an area that's been previously treated, but something that is either symptomatic or more diffuse.
Roy, do you think you would rebiopsy an individual who developed more systemic progression if they were ALK positive? Do you think outside of a clinical trial there's really an indication to do that, or is it a bit more problematic?
That's a tough question. I probably would rebiopsy, though the options wouldn't change that much. It would be more for research purposes. You know, when someone starts to progress, and I would agree with Karen, you know, you can treat them at the local site, but I would look very quickly for one of the trials of one of the next generation drugs, because we know that under the selective pressure of crizotinib, the tumors do develop specific second mutations, you know, this gatekeeper mutation, and both the LDK378 and the AP26113. These are two agents.
It's hard to remember these numbers. I call them license plate therapies, so they get names.
Yeah. And they're both agents, actually. We've had some experience with the latter at Yale. And I've been impressed that these agents are active in the refractory patients. The other thing that is somewhat evident, there's not proof yet, is that these agents do seem to cross the blood-brain barrier a little bit better and have some activity in the CNS. So I probably would. I would biopsy. We actually try to rebiopsy most of these patients on TKIs because there's so much to learn. But looking for that specific mutation wouldn't be necessary for me to put them on a trial with one of these agents. And these two agents that I just mentioned are in pretty advanced clinical trial. You know, one's moving to phase 3 and the other is in phase 2. So there's clearly evident in the refractory population. And now there are even third generation agents, you know, with even more CNS penetration coming down the pike. So this is an area where it's a small group of lung cancer patients, but it's a group where we can have great impact, and the patients will live, hopefully, with good quality of life for a long period of time.
Say hypothetically the patient's in a remote area, they really don't have access to a clinical trial. A, would you rebiopsy in that situation? And B, how would you handle this sort of situation, which inevitably is going to occur?
Well, in that situation, if you didn't have access to any of the agents, you could move to chemotherapy. There are some data that pemetrexed appears to be quite active in this population. Or I'd refer them into one of the centers that had a clinical trial.
They're older, perhaps their car is broken down, they can't quite make it to Yale.
Well, you know, the one thing, you know, we've seen this, Corey, for years since, you know, with EGFR inhibitors too. Don't forget that there is cytotoxic chemotherapy that you can offer these patients too. And, you know, it's actually, I often worry that we undertreat these patients because the patient has one of these drivers. You know, many of them are never smokers, not all. You know, they have such a good quality of life for a year, some 2 years, 3 years, and then probably you should give them the cytotoxic chemotherapy, and many of them don't want it. Sometimes, as a physician, you're reluctant to give it.
So they progress to the point where they are no longer candidates.
Unfortunately, that happens way too often.
I've seen that as well.
Yeah.
Roy, there's a real issue here, I think, sometimes in potentially undertreating ALK-positive patients, that we tend to string them along if they have a driver mutation. We forget that chemotherapy may still have a role. What's your thought?
No, absolutely true. I think that in these patients, in the absence of a clinical trial, If someone clearly is progressing, you don't want to lose your window of opportunity to give them platinum doublet therapy, which in a good performance status patients will have an effect. In fact, some of these patients might even do better than a typical lung cancer patient. So I do think that this is something to always keep in mind, but it's hard because the patients have have done well. They've had a good quality of life, on an oral medication. They're not eager to do it, and I think sometimes as physicians we push back a little bit too, and we need to be careful about that.
So in this patient who's never had cytotoxic therapy before but is finally progressing to the point that you really can't continue the crizotinib, would you give single agent pemetrexed, or would you go to a standard carbo-pemetrexed or carbo other agent combo?
If the performance status is good, and it sounds like it is the way you describe it, I would give a carbo-pemetrexed, a very well tolerated and active regimen.
So let's again change